All right, so you guys are making me feel way more important than I really am. So I'm here because of Mario. He did reach out to me. It has been about 8 months ago, and we sort of formed a connection. We've been sharing information back and forth multiple times over the last few months. And when he asked me to come here and he explained what was going on in this community, I really jumped at the opportunity. And after meeting with several of you this evening, I realized that, and I was actually telling my husband this on the way over this evening, that all communities share commonalities. And I see that in the faces of the people I met this evening. You share the same challenges. You're faced with the same things our community was. What I'm going to do is I'm going to try to go sort of quickly through the beginning of this slide presentation. It gives a little bit of background of where Huntington came from, so you'll know where we are now and the changes. If you Google Huntington, West Virginia, you're probably going to see a lot of negative things. We were in all the way to the international news. We had BBC, we had people from Denmark, we had people from Germany wanting to come to Huntington. And what they wanted to do was ride with the ambulance crews because they wanted to paint that really negative picture of our community. We got to a point where we said no. And it's been a blessing. But I'll share some background. So first slide. I think it's actually probably going to be, I need to change it, don't I? Sorry about that. Okay, that's me. We've already talked about that, but I'll just give you a really, really quick rundown. I've been a nurse for longer than a lot of you are old, I'm sure. I started in the ER. I flew on a medical helicopter for 25 years. And over the last few years, I've transitioned to our county EMS system. They brought me in to do what Mario said was quality assurance type of work, and I was sitting behind a desk, and I really hated it because I enjoyed taking care of patients. I enjoyed interacting with people, and when I got an opportunity to recognize that our community's overdoses were going up and up and up. I was asked to be on several committees and task force, because that's what we do. We form task force, we form committees, and be part of the solution of what was going on. And when EMS was saying, and I know police officers are in this room too, we were saying we've got this horrible problem, and everybody's going, no, we don't. Because it wasn't affecting them. It wasn't until it started affecting them that it made a difference. So first slide talks about our community. What I say is a community in crisis. These are actual pictures that you can look up on the internet at any time, and you will see these exact photos, because this is what was painted over and over and over in our community. Our city population is about 50,000. Our county population is 100,000. Cabell County EMS runs around 35,000 calls a year. That also includes non-emergency transports. Cabell County is all inclusive. Cabell County EMS is all inclusive of the entire county, which is all inclusive of Huntington, West Virginia. So when you see things, it always says Huntington, West Virginia. Just know that it's Cabell County EMS that runs all the calls in the city. So I talked about overdose calls, and you're thinking there's a lot of ways that you can measure what's going on in your community, depending on what the media is painting, what other information is being disseminated. But one of the things that we did, and I was telling some of the people that I was talking to earlier, in 2014, we actually ended up with a new electronic medical record, which was called EMS charts. And for some weird reason, it ended up being a blessing. I created a box that said suspected overdoses. So what that box is a drop-down box for our medical crews. It's not how a call is dispatched. It's what the medical crew decides once they get on scene, what is the cause of the problem that prompted that 911 call. So suspected overdose was the box that we created. That ended up being a blessing and a curse because we started tracking the numbers. So many EMS agencies in our area would say, we don't have any idea how many we have. And people would have to sort through charts individually looking for signs and symptoms of an overdose to identify people that needed help. The OD maps that Heidi uses, and that's one of the tools that Mario spoke of, first responders can actually pinpoint where they are and that it was an overdose. We actually had EMS data for that. Not everyone does, so the OD maps works to function there. But so in 2015, we had 480. By 2016, we had 1,217. And I've got a very interesting statistic that's on down in that. And then by 2017, we had 1,831 calls. If somebody would have asked me about October, I would have said we would have had 2,000 overdoses that year. 2,000 in a community our size. That's a lot. We got to a point where we were averaging about 6 per day. Okay, so I'm going to let you listen to something. And I call this the day that changed everything.
We need an ambulance at 112 Sycamore Street. Hurry up now! These people showed up at my house and they're dying.
Okay, who are they?
So these people showed up at my house and they're dying. If you don't care, click on that one.
Station 2, 112 Sycamore Street. There's an unknown problem, Station 2.
Unknown problem, that's the way it came out. By the end of that day, there was over 28 individuals that overdosed. Our ambulances were going from call to call to call. That was the day that fentanyl showed up in Huntington, West Virginia. So we did an excellent job of saving people that day. We resuscitated everyone we called on. There were a couple that showed up at the hospital without calling an ambulance, and I think one individual died several days later. But the thing that this brought all the attention to us. We were on national news, international news, but we found out not one person that day was offered treatment. Not one. I'm able to tell this story right here because I know her mom. She was a paramedic for many years. Taylor Wilson was the first person, not one of the first. She was the first person to overdose that day. Her family tried desperately to get her into treatment facility. She overdosed and died at home 41 days later. Upon returning from her daughter's funeral, Leanne Wilson said the phone rang. There was finally a bed available. So they tried to keep her at home all that time and just protect her as they were looking for some place to put her. And we realized we've got a problem. And it's not them, it's us. It's all of us. Our community became quite aware that how we were handling the crisis was not working. It was still believed by many that you could arrest your way out of this epidemic. Our police officers were doing their best. They were arresting everyone. They were arresting people that were selling. They were arresting people that were using. They were arresting people that were overdosing. As the numbers spiraled out of control, with nearly 200 individuals overdosing in 1 month in August of 2017, which averaged 6 a day. So if you notice, August of 16 was the crisis day. It increased every single month for the following year. And we still were talking a lot about it. We weren't doing a lot about it. It became very apparent we needed a new way of thinking. Community leaders began working together. Mayor Williams developed an Office of Drug Control Policy. Programs like the harm reduction followed. The criminal justice system developed diversion programs, so through a drug court system. Suddenly, the leaders from Marshall University, which they were not involved in this at all, started to affect their enrollment even. Funny how that gets your attention. We have 2 major hospitals in our community, multiple treatment facilities, city, county, and governments, and we all know in this room, probably if you don't, different entities in the government don't work together so well. So getting city and county people in the same room and getting them on the same page was pretty difficult. Cabell County EMS is a county agency. Police and fire are city agencies, and they function completely separate from us. So to get us all in the same room, agreeing to the same thing, putting egos aside, you know, it's not who gets what or any of those things, it's what's best for the people of our community. We started looking for solutions. West Virginia led the nation per capita in overdose deaths, and Huntington was at the heart of that devastating statistic. Bob Hansen was someone who was in the mental health community his entire life, and Marshall University hired him as the director of addiction services at Marshall, and he's the one that sort of corralled the cats, as I say, because, you know, no one was sure they wanted to be in the room, but he made sure everybody came. And that was what I was so impressed with this evening, is so many different entities are represented in this community. You have treatment providers, you have the university, you have medical people, you have law enforcement, and you're all in the same room, and that's what we did. So I'm really, really hopeful for this community because it reminds me so much of what we faced. We ended up finding this model in Coleraine, Ohio. Sounded like this great idea. Going out and seeing an individual where they were, not waiting for them to come to our office and knock on our door and say they needed help, but going to them where they are. We had no funding, so we weren't really sure what to do. So we ended up finding 2 grants. One was through the Bureau of Justice Assistance, which is a law enforcement-driven grant, and one was through the Office of Minority Health through the DHHS in Washington. Both of them were very new to some kind of model like this. They really weren't sure what to do with us, but they said, you know, you're all in desperate need in your community. You tell us what you think will work and we'll give it a try. And that's sort of where we started. So the composition of the team is EMS personnel, law enforcement, treatment provider. I'll explain a little bit more of how this team expanded, but this was the initial, the way we envisioned the composition of the team. EMS provider, I read an article in the very beginning, I think it was somewhere in Massachusetts. It said, you know, why would you have EMS? Well, one thing for the data, because they have all the overdose data. But also for that medical side, they said that they had gone into someone's home and they were asking, you know, would you be interested in treatment, talking to them. He said, I don't have a problem. There's nothing wrong with me. I don't have a problem. The paramedic that was with the team said, I know yesterday that you overdosed. You were unconscious, unresponsive. You weren't breathing. It required Narcan. We had to assist your breathing. You urinated on yourself. And they were talking to the person. And he stopped and he looked over, and his 3-year-old daughter was in the room, and he realized that she was in the room the day before, and she saw him like that. So he said, yes, I do want help. So there's that sort of medical side of it. Law enforcement. Our officers in the beginning thought we'll just be the safety valve. We'll stand outside and wait. And I'll give a lot of detail about what our officers do now, but they've been so valuable. And when I say treatment provider, I don't specify. We do have peer recovery coaches. We also have counselors. We have sort of 3 agencies that donated their best people to the team, which has been a blessing. The team is what makes this work. So you see down on the left-hand corner, faith-based leaders. They joined the team in July of 2018. The churches in our community kept saying, we want to be a part of this. We want to be a part of this. And we said, okay. I was in a meeting with them. I said, well, you could offer up your church as a safe haven, maybe provide food or clothing when we identify someone. And Bishop Charles Shaw looked at me and he goes, no, we want to be part of the team. So we were so excited about his level of commitment. We knew that we didn't want a sermon happening, but the team ended up being such a valuable component, these faith leaders. They provide support. They said that they had people in their congregations think, is this a moral failing? Is it a character flaw? And one of our leaders came to me and said, now I can tell them this is everyone. And you know what? These are just people. They're real people that are hurting, and if we can help them, I want to help them. And he said, now I can go back and tell my congregation that. So we have nearly 30 faith leaders that rotate on the team. They are provided a very small stipend, but most of them give that money back and help us buy food and snacks and things like that. So they don't even keep the money. Not that I blame them if they did. These are some real pictures. As you can see, these are some of our team members. Virgil, who's holding the Bible, he's just wonderful. Larissa's our paramedic, and she's full-time. And these are some of the articles and things that they've done. So how does it work? How do we get the information? How does this work? So EMS responds to an overdose call. And in the very, very, very beginning, the grant said you will respond to people that have overdosed. This is what your grant's going to do. You're going to reduce your number of overdoses. You're going to reduce your deaths. So we had somebody in the very beginning say, so do you have to overdose to get help? And we're like, oh my gosh, never even thought of that. Absolutely not. So now we take outside referrals. People call all the time. We have a non-crisis line. So it's not a hotline. It's not offered or answered 24 hours a day, but you can leave a message, and the team will go see them the next day after the message is left. From that, they go visit. They attempt to locate the person. So on this EMS record, we have the place of residence. And I was talking to some of the people earlier that if you're a medical person on the scene and you have to make a medical record, generally speaking, law enforcement will take their driver's license out of their wallet, and that's the address that I use to make that chart. 90% of the time, that may be an old address, or it may be their family's address where they used to live. So that's one address. The other address that's on there is the address where the overdose actually occurred. So they go to both places. Our team has gotten to know people so well that generally if they're not there, somebody there will know them and say, well, if you go down the block or something, you'll probably find them, or here's a number. In the very beginning when we went to visit, because sometimes that scene was very confrontational. And that was another thing I think I was telling. We were on an overdose call. If someone overdosed, we would send EMS, we would send fire, and we would send the police department. Now, if you have experienced an overdose and you're laying out on a sidewalk in public and you look up and there's 10 people standing around you with a uniform, all you're going to do is want to get out of there. You know, you're embarrassed. You don't want everybody there. It's almost like a circus atmosphere. So we weren't sure if the team would be welcomed when we went to knock on their door. That very first week, the team came back and they said, the very first door we knocked on, they said, so you're here to check on me? You cared enough to come to my house and check on me and see if I'm okay? And they ended up hugging, and 99% of the time, that's the reaction that we get. Because these are just individuals in need. They need hope. They need somebody to care. And that's what the team does. I've had lots of people say, well, the most important thing, it sounds like to me, is you're saying who you get on the team. And I said, you're exactly right. Because you need somebody that actually genuinely cares. They're not doing it for overtime. They're not doing it because, oh, it's a whole lot easier than working a truck. They're doing it because they care about the people. And that's why we've had any amount of success that we've had, because of these people that work on this team genuinely care. The police officers, and that was one of the things that I was telling Mario earlier, when they first started out, they said, oh, well, we'll be there for the safety component. You know, sometimes you go into neighborhoods that aren't as nice. A lot of times you go into the neighborhoods that are nice, and our team will tell you that. But we'll be that safety portion. Well, within just a few months, all of a sudden, our police officers are carrying the quick response team cards with them when they're on duty. They're calling our people saying, oh, I've got somebody here at a traffic stop. Why don't you all come over and talk to them? They're going to meetings like this and sharing their experiences. We had somebody from Wake Forest University. It's their faith division that they have down there. And they met with all of our team and probably about 20 of our faith leaders. And our police officer spent about 10 minutes explaining how he had been changed by his role on the quick response team and how much it meant to him now. And that he's able to share that feeling of hope and helping with his colleagues. And that's the same thing that's happened with EMS. We bring our people in and we explain to them what the quick response team was. We got their buy-in because they're those frontline people that can make all the difference in the world about whether a program like this will work. So if they're ready for treatment, we make the phone call. We pick up the phone. We call the treatment facilities. In the very beginning, what we realized is that not one treatment fits everyone. We were trying to push everybody to inpatient type settings. And we realized lots of people have a job. Lots of people have family commitments. They can't go somewhere away for 30 days or 60 days. Maybe a medication-assisted therapy in an outpatient setting is a whole lot better for them. So our team realized that you work with the individual and you find out what works best for them because they are the individual you're trying to help. If they're not ready for treatment at that point, then we still have this, what I call medical record. They more or less call it a tracking chart, but a way of going back and seeing them. And a lot of times what happens is we've had individuals say, oh my gosh, I'm going to go with you guys because you're going to keep coming back and bugging me if I don't go with you. So they're a pretty determined bunch. And so they stay in the system. Some of the initial challenges, and I know I've had a lot of people ask about this, was the confidentiality. How do you share client information? This is a very private matter. It's very stigmatizing a lot of times. You don't want that information shared with just anybody. Physical location. We ended up with funding, but we didn't have a place to meet. We didn't have a computer. We didn't have a vehicle. We didn't have anything. No way to collect data, just to write down a person's name and address. Finding out the actual current location of the patient, and encountering clients that were actively overdosing. So our team carries a first out bag. Within about a month or so, they did encounter someone that was actively overdosing. The person answered the door and she goes, "Oh, you're all here." And they thought, "Were you expecting us? We didn't know." And she said, "Well, he's in the bathroom. He's overdosing." So he was physically overdosing at the moment that they knocked on the door. So they were able to intervene. They went ahead and called 911, got an ambulance to respond to that location. But in the meantime, they were able to help the person because they did have that first out bag. How we overcame some of these challenges is the confidentiality agreement is called a business associate agreement. It's signed among all agencies. So the police department signs it. All 3 treatment facilities signed it. Cabell County EMS signed it saying they would share their data. Marshall University signed it so that we could share their research data, but they do receive de-identified data because that's what they want. But they did sign the confidentiality agreement. We actually had to pay an attorney to develop this, and it's been a blessing because that is probably one of the first questions that everyone asks. How do you share that confidential data? And you don't want to breach anyone's confidentiality, and you don't want to compromise anybody, but you want to save lives. So the next level is I developed like a HIPAA form. So every individual that comes onto the team signs that individual HIPAA form too. And I've shared that with multiple people, and I don't care a bit to share it with you guys. So that is people that come maybe for a ride along. That's people that come and like want to go out with the team, because we don't want anyone to film any of our clients. We want to respect their confidentiality. So we make them sign something in the beginning, and that has just reminded everybody to not make this public knowledge. All the faith leaders sign it when they come in. Even in good faith, they might share information among their congregation or something, even if it's good news, and we just didn't want that to happen. Our director ended up donating office space and a vehicle. We ended up with an electronic charting system, which I equate more like a medical record, to keep track of our clients. And we did active education with the first responders to get buy-in. We said, if you don't have that compassionate side, tomorrow maybe you don't have to go back and treat the same person if you spend 30 extra seconds and maybe get a current phone number so we can find them. And they said, that makes sense. So, they became much more responsive to trying to get current information. And they pick up the phone now, and they will call our team and say, I've got somebody I think you all might be interested in talking to. They express some interest, so our team will do that. I'm going to pick this up. I've got visual aids up here. So this is like what you'd find at an open house. It's got a little flip top. It's got our calling cards in it for the quick response team. And we took one and put on every single ambulance. That way they can't say, well, I didn't know your all's number, or I couldn't. They just go grab a handful of cards and give it to the individual. And they actually utilize it. and they've really bought in. We don't hear the stigmatizing talk that we heard 2 years ago because people have changed their view. It has affected everyone in our community in some form or fashion. One of our clergy said that she asked her congregation, she said, who in this room knows someone or you have been personally affected, family, friend, by the opioid crisis? And she said every single person in that congregation raised their hand. So there's no one neighborhood we go to. There's no one housing development we go to. There's no one man or woman. You know, it cuts across every socioeconomic barrier. It cuts across every gender. It cuts across everything. And if we don't think it does, we're wrong, because it does. And the data proves that out. I'll show you at the end of the slide. We do a heat map, and the areas that we thought would be very hot for overdoses weren't the ones that ended up being very hot for overdoses. We were actually surprised. So what does the team do? We refer clients to the harm reduction program if they're not ready for treatment. Harm reduction program is a needle exchange program. So they will exchange and get clean syringes. Also, they do HIV and hepatitis testing there. When they go in there, they go through a gauntlet of peer recovery coaches. So it's not like somebody just handing them a needle and walking away from them. They're talking to them. So we refer people that aren't ready for treatment into that program. We have a really, really good relationship, and I'll tell you what we've done just recently because of some of the things that are going on in our community. Volunteer Day. So using those heat maps, we have identified targeted neighborhoods, and we've gotten together and actually just physically passed out the brochures. Again, we weren't sure how we would be the reception. We know we passed out brochures to people that were actively using. We know that we passed out brochures that a family was pushing their child down the street in a stroller. And everybody said, what are you all doing? And we explained it. And they said, oh, give me one of those brochures. I know somebody. So nobody said, get that out of my neighborhood or wadded it up or threw it down. Very, very receptive. The calling cards on the ambulances. We work closely with multiple agencies, homeless shelters. We've become a resource for them. We continue to train. I know that one of the people I talked to this evening was talking about motivational interviewing. So how to talk to people, and not be judgmental. So we got trained on that. We continue to push out training on what we do in the community. We've added the faith-based component, and we continually update the electronic data collection system, which is, how that goes with data collection. It's very vital, so we end up having to keep abreast of that. When I say CPR and Narcan training, I brought, again, AIDS. So when the American Heart Association heard what we were doing, they provided 1,000 of these to us. And for all intents and purposes, they are disposable mannequins. Literally, this will blow up in about 10 seconds. If anybody's ever taken a CPR class, when you do the compressions right, you hear that click on the chest. These will do that. They have a CD with them that will explain to the family. Now, our medic says if somebody is overdosing, generally speaking, they're not breathing. So rescue breaths are the most important. You aren't going to have to do chest compressions unless they've been down a long time. But the thing about that is, it's a tool for the family. And that's who I'm talking to, Families Against Narcotics. So to give the family a tool that makes them feel like I might be able to help my loved one if something happens was really, really valuable. And we also were provided Narcan kits. Earlier this evening, somebody said, do you leave Narcan? If you don't find anybody, we got door hangers, and we hang them on the door. Now, we were doing that in the beginning, before there was any state regulation on it. You did have to be trained in Narcan. Our paramedics give Narcan constantly. They're certified to do it through the state. That's part of their state protocol for EMS. But they weren't trained to train anyone else. So our medics went to the health department and got trained to be able to train someone else to give it. We hang it on the door. Some people said, well, should you all be doing that? And we said, if you want to get it in the hands of the people that need it the most, you're going to leave it. And I told a story, and I said it makes me cry every time I tell it, but I'm going to tell it anyway. We have a phone number, and it's a non-emergency number. It says on there, if you have an emergency, hang up the phone, dial 911. I went into my office. I could see I had a voicemail. I took it off. And he said, yes, someone left Narcan at my door. And I thought, uh-oh, we're in trouble. They're mad. So I called him back. And I said, yes, my name's Connie Priddy. I'm the coordinator of Quick Response Team. We came to visit, this address, and we left Narcan at your door. And he goes, yes, and I don't need it. And I thought, okay, well, he's mad. He doesn't feel like this is something he needs. And he said, my son died on Monday. And he said, but I want you all to have that Narcan back because that's a life-saving medication. And I said, well, I can send the team back to your door and I can pick it up. And he goes, no, I want to bring it to you. So he met me in the lobby of the EMS administrative building, and he gave it to me, and he goes, I want someone else to have this because it could save somebody else's life. And of course, by that time I'm bawling, and he spends probably about 5 minutes looking through his phone because he wants to show me a picture of his son. And his son looked like he was probably about 35 years old and looked like he was a football player. And this gentleman looked like he was my dad. And I thought, that's what this is about. This is why this matters. And I've got so many stories like that that I make myself cry. But it reminds you of why you're doing it. We use the Cabell County EMS data to do the visits. We do take outside referrals now. I say that we seek to visit somebody within 48 hours because we only work Monday through Friday. So if somebody overdoses on the weekend, we may not get to them until Monday or Tuesday. So that's why we sort of set that 48 hours. Sometimes it's as long as 72 hours. We leave brochures and the Narcan and the CPR mannequins. And we're a resource to help people link to treatment. We don't provide the treatment. So if we have a peer recovery coach from what our local agency is called Recovery Point, it's an abstinence-based facility. Just because he's on the team that day doesn't mean we're going to refer the person to that facility. Again, whatever works for them, and the team will tell you all paths to recovery. So it doesn't matter who's on the team. We work with them. It's a really, I'm a nurse, so I knew how hard the medical system is to navigate, like, an MRI and, being referred to a specialist and which comes first and where do you go and how do you do it. You take that by 1,000% when you are looking at substance use disorder. You don't know who to call. I was one of those cynical people when somebody would say, somebody come in the ER, or I'd fly somebody on the helicopter, and they'd say, well, I tried to get help, but I didn't know where. Or I tried to get help, and there weren't any beds. And I'd say, yeah, right. And then I realized, yes, it's yeah, right. It is really, really a difficult system to navigate. So that's what we do. We make the phone calls. Our team now knows what facilities accept insurance, don't accept insurance, state insurance. Some facilities say you have to test positive for a urine screen 24 hours prior. Some say you have to test negative for a urine screen within 24 hours. So everybody's got different criteria. So our team helps sort of link that and know those answers to those questions. Mario touched on this. I'm going to scan through this really quick so I don't talk too long, and give you some of the graphs and things. I'll bore you with some of the data. But Cabell County EMS reported a 40% reduction in overdose calls between 2017 and 2018. The quick response team came into effect December of 2017. Had somebody say, do you think it was all due to the quick response team? Bless you. Absolutely not. Our community distributes Narcan to the general public. So if somebody's given Narcan at home, they probably are not going to perceive a medical emergency, so they're probably not going to dial 911 and pick up a phone to call an ambulance. So we know that it's not just the quick response team, but still it's a measurable data point that we can show. Again, in 2014 is when we created this. So we didn't create it in response to the quick response team or something. This was already something in place. That's how we saw the numbers going up. That's why we trusted them when we saw them going down, because we were measuring the exact same thing that we were 5 years ago, 6 years ago now. Total cost and savings. So some people don't have a compassionate heart, but some people care a lot about their pocketbook. Well, we figured it to be over $370,000 savings for EMS between those 2 years. How did we come up with that number? Because over 700 less calls of about $500 a piece that were not getting reimbursed, we weren't running those calls. So we looked at that as a savings to the community. At this point, and the slide's a little bit old, I updated the rest of them, so you'll see a little bit more current numbers. But at this point, there was 500 individuals that had been contacted that first year. Of those, about 30% got into some type of formalized treatment. And somebody asked me, they said, how do you know they went to treatment? Did you just hand them a card? No, that's a contact. If we know they went into some kind of treatment, it's because we linked them to treatment, did a warm handoff, and called. Made transportation arrangements, or actually transported them ourselves. And again, everything that's going on in Huntington has contributed to the decreases that we see. So these are just some of the statistics. This is between 17 and 18. You can tell the overdose call number difference, and that's equals that 40% that I was talking about, the 40% decrease. And this is between 18 and 19, and this is a relatively new slide. So what happened between these 2 years, I think I actually have it typed out, and I'll get to it. But we had another decrease. So between 2017, which I consider our crisis year, and 2019, we've had a 52% decrease in our overdose calls. I'll take that. So these are clients served by the quick response team. So you see, we're only finding about 50% of the people. We've got to continue to work on that. Current information is really, really, really important. You go back to their listed residents, you go back to where they've overdosed, and you still may not be able to find them. We have found, generally, a lot of times that we know places that people go. So we have learned where to go, and we've actually gotten a lot better at finding people. And this is more QRT data for 19, and this is the more pertinent slide here. So QRT eligible since our inception, 1,655, contacts made over 720, and we've had over 200 people enter treatment. So that's still running around a 30% success rate. And I don't want to call it a success rate because that's a horrible way to describe that. But it's 30% of the people that we contact enter some type of formalized treatment. And again, I talked about the overdose call decrease. This is, in the University of Michigan, people will appreciate this probably a lot more than they do my slides with pictures. That this is just a short statistical analysis of what our researcher did, with the point of intervention being when the quick response team was formed, and you can see how the numbers trended downward. These numbers don't exactly mirror the others because he separated out the Huntington numbers from the Cabell County numbers just for his statistical analysis. But it's the same exact trend because we have such a small percentage that happen out in the county versus the city. Probably about 90% of our overdoses happen with a Huntington address. I mean, a Huntington zip code, I'm sorry. So what are they doing? Well, they're going out to schools. They're talking to people. We go to the community colleges, try to explain what we do. We're doing the volunteer day. This was the original card, and I've got cards now, and I'll pass them out or just lay them out there. You can get some. I like these better, actually, because they're a little more brilliant. The other ones are sort of look business-y like. We do have a Facebook page. If you look for Huntington QRT, you can find it. Now, the girl that was doing it did go off on maternity leave, so it might be a little bit behind, but anybody that was, if someone graduated from drug court, if there was a recovery celebration, she would put all that on our page. So it was really a good resource. This is the heat map that I was discussing. So what you see here is you see areas of red, and we were very surprised because it wasn't the areas that were expected. So what made this work, in our opinion, was collaboration. And I see that in this room today, and I'm not just saying that because I'm in this room today. It really matters that your community cares. It matters that all, whether it's law enforcement, EMS, treatment providers, the university, faith leaders, your recovery community, they all say, let's try to make this better. And they get together and they talk like this, and it means so much. I got real philosophical, and I said for the greater good, because a lot of people only see things from their eyes. They don't see that greater good, and this is one of those things that you have to work together. Ignoring the issues do not make them disappear. I've had a lot of communities say, well, I don't know what our overdose rate looks like. I don't know how many people in our community have substance use disorder. And if they did, they probably wouldn't like the number, so let's just say we don't have them. When we reported them out going up, that probably didn't put our community in a really good light, but it was something that we embraced and said, it's here. If we care about our people, we're going to do something about it. So do it. A lot of the presentations that I've done, find allies with a like mindset. Because I'll go into communities and they'll say, well, the judges don't believe in this, or law enforcement doesn't believe in this, or the politicians don't believe in this. And I said, find somebody that does believe in it, work with them, and let them work with someone else they know, and then work with someone else they know, and then work with someone else they know. And that's what'll happen. Giving hope is the strongest tool we have in the toolbox. If you can give somebody hope, you can change their lives. And what I found is that it doesn't just change an individual's life, it's changed my life, it's changed the team's life. They really, really, really care about the individuals that they're going to see. And that shows in everything they do. So this is more of the team. I just have pictures of the team everywhere. So I've got bracelets up here. This was something the team came up with because a lot of people like these. Purple is for recovery. It's just got Huntington QRT and the phone number. I've got some of these. One of the things that we did start doing because we had an HIV cluster in our community starting in the fall, and it was truly because we were testing. If you're not testing, you're not going to know. Well, we knew because we were testing. So the health department started providing us with, at first, brown paper bags, and we put condoms in there, referrals to the health department, information about HIV, our brochures, a bracelet, and our researcher, of all people, said, if it's a brown paper bag, it needs to have a sandwich, because that's what you carry, So now our churches, everybody brings in peanut butter, jelly, and bread, and now when they hand it out, they say, are you hungry? Would you like a sandwich? And they hand them a sandwich, and let me assure you, they tell me that it feels like you're handing a steak dinner because everyone is so gracious. And that was our researcher that thought of that. So I love to give him credit because in the beginning, I was telling them, I said he and I clashed because he was wanting, 15 pages of survey filled out, and we were like, no, we're not going to be able to do that. And finally he said, Connie, if you can convince me, you can convince anybody. And now he buys in, he goes out with us on volunteer day, he does everything. But I was presenting this to our advisory board, and they said, a sandwich and a condom, what more can you ask for? So that's it. I've got brochures up here. Thank you for your time.